Hello, I'm Dr. Sonali Saxena, Senior Resident from Department of Dermatology, and today we will be reading about bacterial skin infections. So first of all, we need to know about the bacterial flora of the normal skin. The normal flora of skin varies widely quantitatively from one individual to another. Only few species are found consistently on the skin. Overall, the normal flora on the skin is divided into two types, resident flora and the transient flora. The resident flora are those bacteria or other fungus viruses that grow on the skin and are relatively stable in number as well as in the composition. Their increase in their number results only from the multiplication of these already present organisms and not because of addition from the outside sources. And the second one is the transient flora, where the organisms that lie free on the skin surface without attachment and are derived from exogenous sources in contrast to the resident flora. They are not able to multiply on the skin on their own. So whatever transient flora that we get is actually from the exogenous source, and that is the reason they disappear from the skin in a very short span of time. Overall, the organisms which are present are, I am going to name few of them. Few aerobic organism or aerobic bacteria that are present are gram-positive cocci, including staphylococci, micrococci, gram-positive rods, including corynebacterium, propionibacteria. Gram-negative aerobic bacteria includes Acinetobacter. Among the anaerobic, propionibacterium has a major chunk. But there are multiple factors that affect the successful colonization of human skin by the microorganisms. The factors I am going to enumerate, the few are desquamation, physiochemical condition like desiccation, osmotic condition, acid mantle. There are certain specific inhibitors and there are other ecological factors. In desquamation, what we understand by desquamation is that when the skin when the epidermis desquamate, it sheds off. Along with it, while shedding off, it tends to maintain an environment that is healthy and it tends to maintain the balance of these commensals on the skin. So it is important that the desquamation should take place. Other than this, acid mantle of the skin, as we know, the skin already has acidic pH. So this acidic pH is there to maintain or what you call promote the growth of certain organism and inhibit the growth of other organisms. Other than this, long chain fatty acids, the antibodies, the various serum factors, they all act as inhibitors for the overgrowth of these resident flora or other microbes that are trying to colonize on the skin. And other than this, bacterial interference. These are the various factors that affect successful or unsuccessful colonization of microbes on the human skin. Now we are going to read about the diseases due to staphylococci and streptococci. Among the staphylococci, so most of the bacterial infection on the skin are caused by staphylo and strepto. Other than this, there are certain infections that are caused by corynebacteria as well. So we are starting from staphylo and strepto as they are most common. So it is known as pyoderma. So what is a pyoderma? It is a very broad term for all the bacterial skin infections. So it is actually defined as any purulent skin disease. It is of two types, primary and secondary. Amongst the primary pyoderma, primary means the offending agent or the lesion or the pathology is primary. It is not secondary to something else. It is not a secondary infection. So amongst the primary pyoderma, we have two variants, superficial and deep. If the infection is superficial, that means it is not involving the level below the dermoepidermal junction, then we call it superficial, just involving the epidermis and that too the superficial layer of the epidermis. And further, these are divided into two types, follicular as well as non-follicular. Amongst the follicular, we have follicular impetigo and chronic folliculitis of the leg. And amongst the non-follicular, we have just impetigo. Among the deep primary pyoderma, we have among the follicular deep primary pyoderma, we have psychosis, barbe, furuncle, carbuncle. And among the non-follicular deep primary pyoderma, we have ecthyma, cellulitis, erysipelas, peroneika. So we will be reading few of them in a little detail. Secondary pyoderma basically includes those infections which are secondary, where the primary pathology is something else. For example, acne conglobata. So in that, the primary lesion is acne that is infected secondarily by the microbes. Other than this, hidradenitis suppurativa or dissecting cellulitis of the scalp, where the underlying pathogenesis is not infective, it is inflammatory, and but it is complicated by secondary bacterial infection. So this is a gross classification for pyoderma. Amongst this, we are going to read impetigo in detail. Impetigo, the word impetigo basically means to attack. So this is the most common skin infection in children that we encounter in our day-to-day OPDs. This term should be applied only when infection occurs in clinically normal skin. That is a primary infection, as we discussed before. Infection of previously abnormal skin manifesting as crusting is called secondary impetiginization. So that is a difference between a secondary impetiginization and the impetigo. Impetigo is usually primary. And the most common offending agent among the Staphylo and Strepto is Strepto and followed by Staphylo. Impetigo is further divided into two types, bullous and non-bullous. Staphylococcus aureus is the commonest organism with bullous impetigo. However, the non-bullous form can be caused both by Staphylo and Strepto. So, bullous impetigo, it is again similarly, so we are going to read these two impetigo, bullous and non-bullous in detail, slightly in detail. So in bullous impetigo, again it is commonly occurring in the childhood, but again in that age group it is further more common in the neonates. And overcrowding, poor standards of hygiene are risk factor as for any other bacterial infections. Here what basically happens, the pathogenesis lies in the toxin that is released by the Staphylococcus. We already discussed the Staphylococcus is more common offending agent as compared to Streptococcus for bullous impetigo. So Staphylococcus basically is going to produce a toxin over here, which is known as exfoliative toxin, which is also responsible to cause Staphylococcus scarlet skin syndrome. So this toxin is going to go at the level of it's going to act at the level of epidermis, where it is going to break the cells apart or cleave the cell adhesion molecule known as desmoglein. So the cells will be separated, and this will lead to the formation of a bulla or the vesicle or a fluid-filled lesion that we see clinically, resulting in the formation of a bullous impetigo. So clinical features may usually, a child will present with a thick walled superficial bulla with very little or surrounding erythema. This will persist for a couple of days and then rupture on its own usually, but it will result or rupture with the formation of a yellow crust. The common site of involvement of such kind of lesion is face, but any part of the body, in fact even the mucous membrane can also be involved. In non-bullous impetigo occurs more often in preschool or primary school children. It is transmitted through fomites or even by insects and occurs in hot and humid climates, and even in the rainy season it occurs. So this is a common season for these infections. It clinically present as, it usually the patient will present to us with a vesicle or a pustule or a crust which is honey colored or straw colored, a granular crust. This crust eventually dries up and leaves behind the erythema. Then we have ichthymia, other second infection that we are reading in detail, caused by Staphylo and Streptococcus ichthymia. So it is a deeper variant of impetigo. So impetigo, we say, is a superficial infection. So it's the similar picture, similar thing, similar pathogenesis, but all occurring at a deeper level is ichthymia. It is having a similar etiology and epidemiology as the impetigo. Again, the risk factors will remain the same. The only difference will be in the clinical manifestation. In ichthymia, there will be a thick chocolate colored crust that we have to remember. Thick chocolate colored crust is important, and the base, on examination, if you palpate it, it will have an indurated base with the surrounding erythema. So this is how the ichthymia lesion will look like. The crust will be adherent, and on removal of the crust, so crusts are not easily removed, and if you remove it forcefully, it will leave a purulent ulcer behind. And healing will occur with scarring. So scarring is important. Why scarring is important? Because it shows that the infection was occurring at a deeper level. So anytime the infection will involve dermoepidermal junction or below that, there will be a healing with scarring. Lower limb is the most common site, in contrast to face, which was more common with the impetigo. So this is how you differentiate the two. Other than this, we are going to read a little about folliculitis, which we commonly, so the broader term is pyoderma, but amongst the pyoderma, if the involvement is of hair follicle. If the infection is involving the hair follicle, then we call it a folliculitis. Again, it is of two types, superficial and deep. Amongst the superficial, we need to know acute superficial folliculitis, also known as Bouchard's impetigo, and chronic folliculitis of the leg, and gram-negative folliculitis caused by Pseudomonas is one of the commonest offending agent. And then we have a deep folliculitis known as Psychosis barbae. So superficial folliculitis basically occurs, so any folliculitis occurs as a result of infection or involvement of the hair follicle. So if only the terminal part or the ostium, that is the opening of the hair follicle, is involved, then we call it the folliculitis. Some folliculitis can also be just inflammatory or non-infective in origin. Here we are discussing infective folliculitis only. So causes could be, as I said, could be non-infective as well as both infective. So among the non-infective causes, contact with mineral oil or occlusive dressings or use of adhesive tapes can cause non-infective folliculitis. But we are discussing infective folliculitis, where the most common organism is Staph aureus. Always the most common organism in most of the skin infection will be Staph. And gram-negative rods usually cause, like Pseudomonas or other organism, usually cause folliculitis around the nose. So clinical feature, patient will present to you with a skin lesion which is dome shaped. It could be a papule, and usually a patient will present to you with pustule which is severely painful. On examination, you will find a rim of erythema, a redness around the lesion, and severely painful. The pain will be too much as compared to the size of the lesion, then you can think of a folliculitis. Special type of folliculitis are Bouchard's impetigo, where it usually involves the children, and pustules. The patient will present to you with pustules in crops involving scalp, hair, margin, extremities. And chronic folliculitis of the leg is another important type of superficial folliculitis commonly seen in young males, whereas Bouchard's was commonly seen in children. It is seen in young males, especially from North India. Why? Because here the mustard oil application is a very common practice. It leads to clogging of the pores of the hair follicle and leads to chronic folliculitis. Then we have a deep folliculitis, a deeper variant of folliculitis, where the whole depth of the hair follicle is involved, in contrast to only the ostium involvement in superficial folliculitis. The commonest deep folliculitis that we need to know is Psychosis barbae, where the involvement will be of the beard area, or it could be a Psychosis nuchae, where the involvement will be of the neck area. The organism will be the same, Staph aureus, in both of them. The patient will present with erythematous or red papules or papulopustules with a central hair, and that's how we can identify it is folliculitis. Some crusting and scaling without destruction of the hair follicle is usually seen, and always these lesions are going to heal with scarring. Other than this, we need to know about furunculosis or boils. It is a term, the term is derived from a Latin word meaning petty thief. In this condition, basically what happens, there is involvement. So here it is a extended version or extended involvement of the folliculitis, extended involvement of the hair follicle, where the follicle as well as the perifollicular region is involved. Then it is known as furunculosis. And multiple furunculosis together form a carbuncle. So these terms are related to each other. So if we start from center of the hair follicle, we will get superficial, we will get a folliculitis. Depending on the depth, we will get superficial or deep folliculitis. If it involves the perifollicular region, it is known as furunculosis, and multiple furuncles will form a carbuncle. So furunculosis in patient with furunculosis will present as a single lesion or multiple lesion, where the it usually presents as a tender area that develops into a inflammatory indurated nodule. With in few days, this nodule will become necrotic and will discharge lot of pus. Particularly the pus discharging point is at the follicular opening, and usually such patients may have constitutional symptoms like mild fever. The common site could be lip and cheek. Common site could be extremities is usually a common site, but if involvement of cheeks are there, we always need to rule out a cavernous sinus thrombosis. And in the carbuncle, it is a term that means a small piece of coal. That basically means literally the affected area will be very very red. It will be it will look like a burning coal, very red, and there will be multiple pus points. On examination, the lesion will be very tender, very painful and firm. On examination, it will be very firm and indurated, and we will be able to see multiple points or multiple discharging from multiple points instead of one point in a furunculosis. and common sites are back of neck, shoulders, hips and thighs, and definitely a patient is going to be toxic because the source of infection or the seed of infection is too much. So patient will be toxic and patient will have fever, and in untreated cases and in the severe cases it can even lead to death of the patient. So it is very important to start appropriate antibiotics. Hidradenitis suppurativa is another important chronic suppurative inflammatory condition. So it is a kind of, which we have already discussed, it's a kind of a secondary infection where there is disease of the apocrine glands in the surrounding tissue followed by infection of the blocked area. This usually occurs after puberty when the apocrine glands are fully developed. The common sites are axilla in females and perineal region in males. A clinical feature, patient will present usually with a tender inflammatory form to soft swelling, which subside in few weeks, and it is very very painful, and on healing it leaves scars and cord like bands, for which even we have to operate the patient for contracture or scar removal. Erysipelas and cellulitis are other important infections that we need to know. Erysipelas is caused by streptococcus, as well as cellulitis is caused by again streptococcus. The difference between the two is again the depth of the involvement. The moment erysipelas is a more superficial infection where there is a large painful tender area, red area, and patient can also have fever. The margins, you can make out the margins are very well defined with erysipelas, whereas in cellulitis it is, the margins are absolutely it is difficult to make out the margins, the borders are indistinct, and systemic symptoms are more with cellulitis, and in untreated cases cellulitis will convert into necrosis. So it's very important to go for the management with appropriate antibiotics. Other than this, we need to know staphylococcal skin syndrome and toxic shock syndrome. Staphylococcal skin syndrome is caused by again Staphylococcus aureus. It is because of the exfoliative toxin or epidermolytic toxin that is produced by the organism, and here the patient will present to you with the rash, the eruption that will appear suddenly, and on taking the history, the patient will give, or the relative will give, the history of upper respiratory tract infection. Over a period of time, the skin will become severely red and tender on touch, and involvement of face and proximal flexures are very common. With time, on examination, the pseudo-Nikolsky sign will be positive and flaccid blisters will also appear. This is known as staphylococcal scalded skin syndrome. It is a condition which has a very high mortality if not treated in time. Because of the vesicles and the erosions that are being formed, with period of time the sheets of skin will fall off, and the skin will shrink and fall off. It is also known as potato chip desquamation. Management will include fluid and electrolyte balance along with the antibiotics, and even anti-staphylococcal drugs should be administered more specifically. Toxic shock syndrome is another important condition caused by Staph aureus. Again, the toxin is involved, but the toxin is different from the SSS. It is a toxic shock syndrome toxin 1. There are two forms, menstrual forms and the non-menstrual forms. In both the forms, clinical features are similar, and it usually present as a rash that appears on day 1, followed by maculopapular or papulopustular, and desquamation that occurs after 1 to 2 weeks. The features of internal organ dysfunction can also be there, and again it needs to be treated immediately, otherwise mortality can be high because of the hematological or even metabolic abnormalities. So that's all about the skin infections. Particularly we covered bacterial skin infections.